about the CSI guidelines 2023. So if we talk about the management of dyslipidemia in ACS, what you should do is obtain a non-fasting lipid profile within 24 hours. What I commonly do in ACS is I give very high dose of atorvastatin, that is 80 milligrams, or 40 milligrams of rosuvastatin, and along with ezetimibe. So we had a study also that was going on, and it is really shown that it is useful. So after this initial regime, you do your lipids again after a month. And if your LDL-C is less than 55, then if you are able to get to the guidelines, continue the oral drugs, and then probably you can monitor every 3 months. But if your LDL is still more than 55, then you can add bempedoic acid because you've already given high dose rosuvastatin or atorvastatin along with ezetimibe. And still, if you're not able to get the guidelines after 8 weeks, then you should add a PCSK9 inhibitors, that is Inclisiran. So thereafter you can check the lipids again maybe once after 3 months, at 6 months, whether you're getting towards the goals or no. And this is the proper lipid management in the setting of ACS that globally, not just CSI, globally we attain. So the Cardiology Society of India, that is CSI, guidelines recommend that in the subset of ACS, if an LDL-C target of less than 55 is not achieved with high intensity statins, ezetimibe, bempedoic acid, then non-statin therapy like PCSK9 inhibitors or Inclisiran should be administered. And again, we have the recommendations for primary non-familial hyperlipidemia or mixed dyslipidemia. So very high risk patients definitely bempedoic acid, ezetimibe and Inclisiran are available in primary care and do not require initiation by specialist services. PCSK9 inhibitors may be available for prescribing in primary care and see the local initiation pathways. It is very important because these patients are a very high risk subset of patients. So you need to get the goals. Otherwise, they would be at a very high risk of developing coronary artery disease or ASCVD events in the future. And these are the recommendations. Basically, you have to get your target straight. So these were some important questions that I thought that I should address during my talk today. And it's a wonderful drug. And this has been available just recently in our country. Earlier, we have been using statins, there is no replacement. But in the patients who are statin intolerant, definitely this would be the best drug that you would have. If you are not getting your achievable targets, it is better to start a drug like Inclisiran, which is given at day 0, then 3 months, and then 6 monthly. And monitor the patients. Try to tell them to be on time. It is important to educate our patient population, our physician population, that these are the goals that we need to attain. Otherwise, the patients would be high risk. And this is how, we apply our guidelines into our clinical practice. Thank you.